Hello, many known faces here today. The good thing about presenting when the moderator is one of your best friends is you can hardly get very tough questions at the end. So when you will, good. Listen, so when Carlo told me to talk about PVI, I said this is basically too easy because we perfectly know that the only thing that has been proven that works in AF ablation is pulmonary vein isolation. So this is the first pass procedure that we do in every patient, independently on which type of AF he has. We will isolate the pulmonary veins. Now I have a lot of slides. I will try to get through them relatively fast, but I did it on purpose. The first two slides, or the first couple of slides, will be relatively chaotic, but they all have one message. You will see the Kaplan-Meier's, no matter what paper you open, the Kaplan-Meier comparing AFib ablation and AADs is always the same. Slight differences, but you will see. So we know that PVI, why do we do PVI? We know that the main triggers of pulmonary vein isolation lay in the pulmonary veins. This was discovered by Saguer, the famous Bordeaux group, a few years ago now. And since then, targeting these structures has proven, especially at the beginning in drug-resistant patients, have proven very effective in treating pulmonary vein isolation. Now, the AF guidelines of 2020, as you can see, put catheter ablation as a two-way, first-line procedure if the patient was agreeing with it. Now, if you see what is happening today, AF catheter ablation for PVI, only PVI, should or may, but anyway, should or may be considered as first-line rhythm-controlled therapy to improve symptoms in selected patients with symptomatic PAF. Now, this is, for me, the way we are going. We're slowly going towards the first-line therapy. Why? Because AADs, as you will see shortly, don't work in most of patients, and because we're having tools that are making it so easy, so safe, that we can propose this to our patients, and we will talk about this shortly. Now, I was talking to you about the Kaplan-Meier's. As you can see, this is a paper by very famous paper by Wilbur. Catheter ablations versus AAD drug therapy considered anything freedom from AF, symptomatic atrial arrhythmia. Any atrial arrhythmia was better with PVI if compared to AADs. Same thing in the famous A4 study. This goes back in time. Now, cryoballoon came on the market a few years ago. Groundbreaking technology permitted us to do the same procedure reproducibly in every patient in a very safe and fast manner. Again, crushing evidence that PVI is better than AADs. Cabana, same thing. I continue. I swear these are only a couple of slides. But again, PVI group better than antiarrhythmic drugs. No matter how you put it, no matter how you study it, it will always give a better result. Okay? And what is extremely important is that if the earlier you treat the patient, the better results you will have with PVI. Now, considering the fact of the beautiful presentations that we're giving this morning, showing that the more AFib moves on, the more it becomes a complex disease, it is obvious that the message should be to ablate as soon as possible in patients presenting with paroxysmal atrial fibrillation. Why? Look at these studies. Cryoballoon as initial therapy for atrial fibrillation. That was the paper by Wozni showing a crushing evidence that PVI is better than AADs in first-line therapy. First-line therapy means that these patients are virgin to any therapy, have never tried AADs. Okay? Same thing here. This was the paper we co-PI'd with Malte Kunis. Again, cryoballoon ablation versus antiarrhythmic drugs. And believe me, we were very stringent in the follow-up. Very careful to see if these patients were showing any sign of AF. And what is very interesting is that this Kaplan-Meier tends to open up. If you would analyze these patients 5 years from now, you would have an opening of the scissor that seems quite small there at the end of 1 year, but it does open up very much because we're analyzing on the long term. Again, as you can see, this electrical isolation of the PV is required during all AF ablation procedures. Again, I could not stress this any more than this. PVI has to be performed in any catheter ablation procedure for AF. It is the mainstay. You cannot get around it. For me, it's not only an advice to do, it's an imperative. We've heard about new technologies showing where AF originates from. We have used a few, but PVI is absolutely a must. So how did we do PVI? Well, mainly PVI it has been created using thermal catheters, cryoballoon ablation, cryoablation, or point-by-point ablation. Now, these were the two mainstays of catheter ablation. According to me, today, to perform a PVI, it's absolutely absurd to go point-by-point around the PVs. This is like, I don't know, it's like taking a boat to go to New York. You know? And you probably would get the same result, even if, depending on the operator experience, but single shots are there to stay. Single shots are the best way to ablate atrial fibrillation, okay? Not point by point, no way. But there are limitations to thermal energies, big limitations to thermal energies. First of all, lesion durability. This is an analysis coming from the Hamburg group showing that in redo patients, up to 2.1 PVs were reconnected electrically at the repeat procedure after radiofrequency versus 1.4 cryoballoon. But still 1.4, you consider that usually a patient has 4 PVs, 1.4 reconnection, that's not the result you want, right? Collateral damage to adjacent tissues. Of course, thermal energies propagate their thermal energy to other neighboring structures. Atrioesophageal fistula, PV stenosis, phrenic nerve injury. Atrioesophageal fistula, if anybody has experienced this in their own career, and I did, is the most dramatic complication that you can absolutely have in any patient practice. The patient is coming in with a disease, namely paroxysmal AF or persistent AF. He can live with that disease. It's not a terminal cancer. And you create something that basically has 90% of death rate. Okay, so atrioesophageal fistula is the reason why today, according to me, we are moving away from thermal energies. Thermal energies are being abandoned thanks to the advent of this pulse field ablation, which consists in creating electrical fields that are applied to the cardiac tissue, leading to disruption of cellular membrane integrity and cell homeostasis, and basically the cells die by apoptosis. Okay? This is the best energy you can use. It is the most selective. It's the safest, as I will show you. And it's starting to be compared to thermal energies, and it's winning on all fronts. Okay, so, well, the catheter that has been used the most is the Farapulse system. I think we totalized just in the UZ Brussels 1,300 procedures until now with this catheter. And as you can see, the advantage of this catheter is that it has a basket shape and a flower shape, permitting to oppose the basket in the PVs, the flower more antrally, and if you want, you can also perform a posterior wall without hurting the esophagus, because it does not propagate to the esophagus, which is really what we want. We want a safe procedure for the patient. This is an elective procedure. This is often not a life-saving procedure. Okay, this is what the Farapulse looks like. As you can see, all the industry is pointing towards this technology and this way of giving energy. And you see that catheters come all in various forms and shapes. You have the Farapulse, you have the Pulse Select, you have the Affera. Most of them are available in our lab. This is what the philosophy of our lab is, to use more and more and different types of catheters to compare them and to try to choose the best catheter for our patients. Okay, again, so how does PFA work in lesion durability? Well, if you manage to find the optimized energy or the optimized way of giving this energy, you will see that you will basically reach permanency of PVI in nearly 100% of veins. Okay, at least with the Farapulse catheter. Every catheter gives PFA in a different way. The algorithms differ in each catheter. So each catheter has to undergo an optimization of the way to give this energy. Collateral damage to adjacent tissues, I already told you basically that PFA is safe. So PFA, this is a very interesting study, bench study, showing that if you would apply PFA directly on the esophageal tissue, you would have no lesion at all. Okay? Again, if you apply PFA on this on the esophageal tissue, as you see, RF shows necrosis, inflammation of the mucosal disruption. You also see abscesses near to the lesion, whereas if you apply PFA in the heart, you will see on the esophagus absolutely no anatomical or histological differences or differences if compared to RF. PV stenosis. Okay, this has been, so PV stenosis luckily is a complication that we see less because we tend to ablate outside of the PVs with RF. Again, point-by-point radiofrequency for PVI. I mean, there are better tools to do it. But anyway, if you ablate outside of the PVs, you have obviously a lower chance of having PV stenosis. But again, if you look at the two squares below, you will see that PFA basically gives no stenosis at all. But if you compare to RF, which is 12% by PV, which is 12% of the diameter reduction, and in 32.5% of patients analyzed. This is quite big, and this, according to me, is intolerable today. So what is our experience? I'll talk about our scientific experience. So I have to be honest, we have very prolific fellows who are led mainly by Dr. Pannone and Dr. Della Rocca in their scientific courses. They are publishing like hell. I mean, this is really unbelievable. And they have created collaborations with various centers. As you can see, these are just a few centers of our collaboration. And actually collaborating with various centers makes data more real and more, let's say, reproducible. So this was a propensity match score analyzing various type of ablation technologies. So cryoballoon, radiofrequency, and pulse field ablation. And in a very sizable amount of patients, we're talking about 1,500 and more PAF patients. And what we saw is that, again, PFA won on all grounds. So procedural and dwelling times were significantly shorter with PFA. Now, for non-EPs, this might mean nothing, but I will show you later on what a PFA procedure takes you to. But if you can proceed to 6 AFib ablations in one morning compared to what we used to do 2 or maybe, 3 maybe, well, then, you can plan it better. You can plan it better, you can shorten your waiting lists, and certainly being a more reproducible procedure, you can be sure that the patients will be better doing than with other technologies. Overall complications rates were lower also with PFA. And the Kaplan-Meier obviously in this case did not show a superiority with PFA for all atrial tachyarrhythmias, but you can see a tendency here for as less AF recurrence if compared to the other technologies. But again, we don't want to speculate. We will see this difference in time, but procedural times are shorter. LA dwelling time, which is the most important. Remember, the biggest complications occur when you keep your catheter too long in the left atrium. When I see 5-6 hour procedures, it's at a certain moment you should stop the procedure and maybe reschedule. But there are times of procedures who are too long. We cannot accept today lengthy procedures with the technology we have. We were part of the manifest, 17,000 patients with AF. Okay, showing again, this was a huge registry and what you see clearly is that the related complications in PFA were mainly vascular complications, punctures, hematomas and whatever. But there were very few related complications to the technology itself. Again, this is another meta-analysis, another systematic review meta-analysis. Sorry, the other one was a propensity score. This is a meta-analysis, again, from Dr. Vetta. This time only comparing PFA and cryoballoon. And what you saw that acute procedural success on a PV basis was significantly higher with PFA, and acute procedural success per patient was significantly higher with PFA compared to cryo. And we're talking about a very performing technology with this cryoballoon ablation. Okay, these are the results. Procedural time much shorter, fluoroscopy time shorter, although we can do better than 14 minutes. Major complications was comparable, but again, vascular complication. And the overall complications were higher in the cryo because we had more phrenic nerve palsy, which is another advantage of PFA because it does not give phrenic nerve palsy, which most of the time is absolutely asymptomatic. But if you have a marathon runner that is having episodes of AF and with a phrenic nerve palsy, you change his life, you worsen his life, obviously. Okay, this is, how do I go back? Okay, anyway, this is the Perfect PAF trial, which was an investigator-initiated trial from our center, non-sponsored, this is important to say. 6 European centers included, comparing cryoballoon and pulse field ablation on a randomized one-to-one fashion. You can see the 6 centers here. So what you see is that you have a higher rate of first pass isolation in all pulmonary veins with PFA. This is a peri-procedural study. It's not an outcome study yet, but we're analyzing our data on the outcome. What you see that PFA is faster than cryo, and cryo is already fast. For non-ablaters, cryo is already fast. Is significantly faster with very, very low dwelling times. PFA time is more predictable. For us, it's mandatory. We need a predictable procedure because we're performing up to 10 procedures a day. So we're a high volume lab. We need absolutely a predictable procedure. These are the variants. PFA in our randomized trial was also safer, reducing 91% fewer perioperative adverse events, which is obviously related to the fact that cryo can give phrenic nerve palsy. PFA does not give phrenic nerve palsy. PFA saves procedure cost. Now, we cheated here because we didn't count how much the catheter costs. But if you look, saving time in today's world means saving costs, and this is absolutely mandatory in the economical background, in the economical situation we're finding each other. Conclusions. Oh my God, I'm really right on time. Catheter ablation is obviously the more effective control strategy in AF patients. Without any doubt, PVI is the mainstay and should and has and must be performed in every catheter ablation. Don't believe these guys showing you maps and then you ablate there and the patient magically converts to sinus rhythm. It just doesn't work like this. Or maybe it works once. You can win the lottery once if you play. Non-thermal energy is here to stay. It is not something experimental anymore. PFA is being used, has been performed in more than 100,000 AFib ablations around the world. So this is absolutely the way to go. It significantly reduces procedural durations, it improves lesion durability, and it prevents the risk of collateral tissue damage. I thank you for your attention.